Imagine this. You go to the doctor for a routine checkup, feeling perfectly fine, and leave with a diagnosis of pre-disease. You're prescribed medications and you're scheduled for follow-ups. But here's the question. Are you actually sick? Or are you just being labeled as sick because of shifting disease definitions? In my first video from doctors to social workers, I discussed the concept of health as defined by the WHO. To recap this definition, it is a state of complete mental, physical, and social well-being, and not just merely the absence of disease or infirmity. While defining health is challenging, defining what a disease is even harder. How we define disease affects not only our health, but also the medications we take, the treatments we receive, and even the cost of healthcare. Welcome to PCP Lens, where we journey through metrics, money, and madness. My name is Sudeep Bansal, and I'm a primary care physician in Connecticut, and I run my own medical practice. In this video, we're going to explore the fascinating and sometimes controversial world of disease definitions. We'll talk about how diseases are defined, why those definitions change, and the ripple effects those changes have on healthcare. The academic literature has used several frameworks to define disease. In this video, I'm going to focus on the biologic or the medical framework. The first step in the biologic pathway is etiology. The etiology of a disease is the study of the factors that cause it. These factors can be a single cause, such as bacteria, which can cause pneumonia, or a more complex cause, such as a combination of multiple environmental and socioeconomic risk factors, which cause heart disease. The next stage is pathogenesis. In this stage, the body's biological processes start behaving abnormally. For example, a bacterial infection may cause lung invasion and start the destructive process, but the person still does not have any symptoms. Also in this stage, the body may be able to fight off the infection and get rid of the bacteria without any antibiotics. In the biologic dysfunction stage, the body starts showing signs of damage because the disease is progressing. Continuing with the pneumonia example, in this stage, the bacteria damage the lung lining and the lungs start filling up with fluids, which decreases oxygen supply. In the next stage, biologic dysfunction can be detected with abnormal biologic markers, such as an increased white blood cell count or a CT scan being positive for pneumonia. Next, people start developing clinical symptoms, such as difficulty in breathing, leading to the diagnosis of pneumonia. And the last stage is temporary or permanent disability or death. Again, continuing with the pneumonia example, unchecked pneumonia could lead to either temporary or permanent use of an oxygen tank to help with breathing or death from pneumonia. Some of you might have heard the term natural history of disease. This term assumes that we already know what the disease is, or at least its main features, and then work backwards to figure out how it develops in the human body. But when I talk about biologic pathways, I'm looking at things differently. I'm thinking about the process moving forward, not backwards, without assuming that every abnormality in the human body will automatically lead to disease. This is an important difference, especially in modern medicine. Today we have tools like biomarkers and advanced imaging that can spot things in the body that might seem off, but we don't always know what those things mean or how they'll progress over time. Often we try to fit these findings into existing idea of disease, which can be convenient for the way the medicine is practiced currently. That said, the idea of biologic pathways is still a simplified way of looking at the incredibly complex processes happening in the human body. Not everything happens in the same order or follows the same steps that I laid out before. But starting with the concept of biologic pathway can help us figure out where in the process we might want to define something as a disease, or whether we should even call it a disease at all. When defining a disease, we have to consider our goals. That is, what are we trying to accomplish with this definition? Help diagnose and treat people to relieve symptoms and to prevent serious outcomes like disability or death? Stop future symptoms, disability or death before they happen? Prevent the spread of contagious disease? Create a shared language so that everyone understands what we're talking about. For example, when I say John has pneumonia, everyone understands what pneumonia means. Make sure that healthcare resources are used effectively. Support research to learn more about the disease and develop better treatments. When we think about the goals mentioned earlier, we need to decide at what point in the biologic process we should define disease. If someone already has symptoms or disability, having a clear definition of the disease helps doctors diagnose and treat it effectively. But when there aren't any symptoms yet, defining a disease becomes much more complicated. It's about weighing the pros and cons. The benefits might include preventing symptoms from ever showing up, avoiding disability or death, or stopping a contagious disease from spreading. However, there's also risks to consider, like side effects from treatment, the cost of these treatments, both for the individual and to the society, and the time and productivity lost to things like taking medications, going to doctor's appointments, or getting lab tests done. Let's look at examples of some diseases that have been defined in each stage of the biologic pathway, so hopefully this concept becomes a little bit more clear. Let's start with the root cause of a condition, its etiology. For example, tuberculosis is defined by the presence of bacteria in sputum, even if there are no symptoms or signs of disease. This definition is important because tuberculosis is highly contagious and poses a significant public health risk if people don't receive treatment for tuberculosis. Next is pathogenesis, which refers to the early biologic changes that happen as a disease begins to develop. For instance, Alzheimer's disease, amyloid plaques and neurofibrillary tangles start forming in the brain long before symptoms like memory loss appear. Moving along the pathway, we have biologic dysfunction. Gilbert syndrome is an example. It's a harmless condition where the body has trouble removing bilirubin, leading to mild jaundice. Next are abnormal biologic markers. For example, a high blood pressure over 140/90 or elevated fasting blood sugar over 126 are markers for hypertension and diabetes respectively. These markers don't always mean someone is sick, but they signal a higher risk of future symptoms. This also raises an important debate. Are these true diseases or are they just risk factors for disease? The goal in identifying these markers is hopefully to prevent more serious problems later on in life. When we reach the stage of clinical symptoms, the disease becomes much more obvious. For example, pneumonia often presents with fever and difficulty in breathing, and a constellation of other clinical signs and symptoms, which defines pneumonia today. Treating it with antibiotics helps the body fight the infection, resolve symptoms, and prevent complications and disability. Finally, we have disability or death. Stroke is a good example. Many people seek medical care only after stroke has already caused some level of disability, like paralysis. In these cases, treatments like aspirin and statins can reduce the risk of future strokes, while physical therapy helps restore or improve strength. At this stage, the focus is on managing the condition and improving quality of life. As we've seen, defining a disease at different stages of the biologic pathway isn't always straightforward. Some conditions could be classified under multiple stages depending on how you look at them. For example, you could classify Alzheimer's disease under the pathogenesis stage when amyloid plaques start developing, or under clinical symptoms when the person starts becoming forgetful. This highlights how subjective and complex the process can be. Scientific, medical, social, and even economic factors all play a role in shaping disease definitions. If we define Alzheimer's under pathogenesis, the drug companies will create and sell drugs to decrease amyloid plaques in the brain, which may or may not prevent clinical symptoms in the future. That's why these definitions are often debated and continue to evolve over time. Using the forward-looking term biologic pathway instead of the backward-looking term natural progression of disease makes defining a disease more challenging. When we use the term biologic process, we are forced to face the uncertainty of where normal ends and disease begins. Let's take a look at a couple of examples to understand this better. The first one is grief and depression. It's really difficult to draw a clear distinction between normal grief and clinical depression. Over the years, DSM, the manual used to diagnose mental health conditions, has changed its definitions, and it recently added a new condition called prolonged grief disorder. Why? Some argue that it's to better define and distinguish between normal and abnormal grief patterns. Others suggest it might be a way to medicalize grief, allowing pharmaceutical companies to sell more antidepressants. Either way, it shows how tricky it is to define when normal emotions end and a disease begins. The next is cancer. Our bodies naturally produce a few abnormal cells called dysplastic cells during normal cell turnover. These cells are usually destroyed by the body's immune system. But when do these cells stop being normal and start being a disease? At what point does their presence become cancer? This is another example of how blurry the line between normal and disease can be. When we use the backward-looking term natural history of disease, especially for something as emotionally charged as cancer, it creates a bias. It pushes us to identify and eliminate every single abnormal cell that the body produces, which can lead to overdiagnosis and overtreatment. On the other hand, if we think about it in terms of the biologic pathway of dysplastic cells, we might ask different questions, like, what will happen to these dysplastic cells over time? Will they ever progress to cause symptoms, that is cancer? This might sound a lot like a debate over words, but the words we use, like natural history versus biologic pathway, shape how people think about disease. And those perceptions influence how we spend our money on healthcare and how we approach treatment. So it's not just about semantics, it has real-world consequences. Building on the idea that defining disease is complex and constantly evolving, it is important to recognize how these definitions change over time. These changes often reflect advancements in science, medicine, and public health priorities, and often the pursuit of profits. Let's explore three common ways disease definitions evolve. One way definitions evolve is by creating new categories of pre-disease. These are designed to identify people at high risk of developing a full-blown disease with the hope of intervening early to prevent it. These categories are often based on measurable biomarkers or thresholds. Some examples include prehypertension, which is now called stage 1 hypertension, prediabetes, and osteopenia. The goal of creating these categories is to reduce future disease, but it also raises the questions about overdiagnosis and whether labeling someone at risk might lead to unnecessary treatment or anxiety. Another way disease definitions change is by lowering the thresholds for diagnosing a disease. For example, the definitions for hypertension and diabetes have shifted over time, with lower blood pressure and fasting sugar levels now being used to classify these conditions. That means more people are diagnosed with hypertension or diabetes than before because of these lower thresholds. The goals of lowering the diagnostic thresholds is to prevent or delay future symptoms and disabilities. However, there's some irony here. Both pre-disease categories and lower thresholds are meant to reduce future health problems, but they also blur the line between normal and disease. This has sparked debates, especially around conditions like prediabetes, with some experts questioning whether it's even a legitimate disease. The third way disease definitions evolve is by diagnosing conditions earlier in the biologic pathway or using new diagnostic tools. The idea is to catch diseases sooner to reduce future symptoms or disability. For myocardial infarction or heart attack, the definition has shifted from being based on symptoms to EKG changes and now to highly sensitive biomarkers like troponins. For rheumatoid arthritis, which used to be defined by joint deformities causing disability, it's now routinely diagnosed using autoantibody biomarkers in blood. And then the definition of cancer has expanded from relying on symptoms to include nodules or polyps found during screening. New tests like cancer in blood cells aim to detect cancer even earlier in the pathway. The definition of depression has broadened over time to include a wider range of symptoms and even grief or bereavement, which were previously considered normal emotional responses. These examples show how evolving disease definitions reflect a growing understanding of biology and medicine, but they also highlight the challenges of balancing early detection and prevention with the risk of overdiagnosis, overtreatment, and medicalizing normal variations of health. When it comes to defining diseases, there's a lot at stake. With all the scientific uncertainty, the blurry line between what's normal and abnormal, and the influence of social and economic factors, getting the definition right has major consequences. It doesn't just affect health outcomes, it also creates new markets for selling medications. There's growing evidence that pharmaceutical industry plays a big role in shaping disease definitions and clinical guidelines to expand its market. For example, when new biologic markers are discovered, like troponins for detecting cardiac injury, they are often retrofitted into existing disease models, such as using troponins to diagnose a heart attack, widening the definition of a heart attack. Pharmaceutical companies take advantage of these changes, marketing drugs that were originally approved for diseases with stricter criteria or higher thresholds to a much larger group of people after the definition becomes wider. This can lead to overdiagnosis and overtreatment. Because of this, some experts have suggested that medical evidence should have an expiration date. Medications that were approved for diseases defined at later stages of the biologic pathway might not work as well when disease is redefined to include earlier stages. These drugs should be restudied to make sure they're still effective under the new definition. Take beta blockers, for example. They've been the standard of treatment after a heart attack for years, but recently the REDUCE-AMI trial showed that beta blockers might not be effective in the era of coronary artery stents, especially for people with normal heart function. Despite this, prescribing beta blockers after heart attack is still considered a quality measure, and the guidelines haven't changed since this original landmark study. The most expensive thing in healthcare is a doctor's pen, but what often gets overlooked is the role that the pharmaceutical industry plays in shaping the conditions under which doctors prescribe medications. By influencing disease definitions and clinical guidelines, combined with aggressive marketing, the industry creates a system where prescribing their products becomes a default. This even extends to cultural expectations. Patients often expect a prescription as part of their care. The reality is that diseases are complex, and many don't have good solutions, especially when they're defined earlier and earlier in the biologic pathway. Doctors who try to have these nuanced discussions with their patients or go against industry-driven guidelines risk legal liability for not following the standard of care. So is the most expensive thing in healthcare really the doctor's pen? Or is it the unseen hand of the pharmaceutical industry working alongside large consolidated health systems that creates the illusion of choice? Since doctors hold the pen or click buttons in the electronic health record, they're often blamed for rising healthcare costs, while the larger forces shaping the costs remain hidden. You can find a written version with references to the material and an audio podcast version of this video on pcplens.com. If you like this video, please consider becoming a subscriber on pcplens.com. Thank you for watching this video. Thank you, take care, and goodbye.